We are here at the Collision Conference doing some impromptu interviews. We're going to have a conversation with Emma here, and I'm going to let Emma introduce herself and tell us a little bit about the work that she does.
Hi, I am Dr. Emma Bell. I am a bioinformatician at the Princess Margaret Cancer Centre. I'm not really sure where I'm supposed to be looking right now, so... Okay, I can do it. I can do it. So my thing is cancer genomics and sex and gender health equity. I think the three biggest issues in terms of sex and gender health equity right now are transgenocide, intersex neonatal genital mutilation, and the postdoc crisis. I am a great deal of fun at parties because I recognize that all of those are things that people definitely want to talk about at length. I'm here at Collision because I want to look at how other people are approaching health equity issues, data-driven solutions to health equity issues, and what I can bring from outside of academia to the academic space. Because I feel like what we're doing right now isn't working, so why not try new things?
Yeah, that's amazing, and so thankful that you reached out and that you're here. And I think that, we need to start having these conversations about some of the gender-based violence that we've been seeing. The tone is very, 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 I don't want to say just angry, but anger is a part of it in terms of people not being understanding and accepting. And I think that, we have a role to play as healthcare providers and people within this space to actually, have these conversations. We actually are going to have, hopefully, at some point in time, Faye Johnson come on and have a conversation with us. But yeah, there's a lot of work that needs to be done. Would you want to tell us maybe what are some things that we should be looking out for in terms of how we can support as podcasters talking and furthering the conversation on health equity?
Okay, so the biggest
particularly in your field.
Yes. The biggest thing that folk in biomedical and healthcare spaces right now can do, particularly those who have a platform, is to talk about the science behind sex and gender as we understand them today. Because the anti-trans lobby, they very commonly use this, it's anti-scientific to talk about sex as if it's not a binary thing, as if biology hasn't spent 3.5 billion years of trial and error to become cleverer than we are. It's the one thing that you learn as a biologist is that it's always more complicated than you thought. It is never simple, it is never black and white. So why would we treat this particular biological trait as a very clear-cut binary? So there are scientific, sociological, biological, and psychological ideas that we've laid down. We laid down in the 1990s that contemporary society hasn't caught up to. And because the biologists, the biomedical researchers, and the healthcare workers aren't filling the space with their voice, there's this void, and the anti-trans lobby are taking advantage of that. So yeah, the biggest thing that anybody with a platform and anybody with a science background can do, a biology background, a medical background, is to talk about the scientific basis of sex and gender. Because these aren't complicated ideas, but they're just not widely understood. And that's the first step to combating this hate that we're seeing manifesting.
Yeah, that's amazing. I'm going to pass it to Sarah.
I'm just really interested in hearing a bit more about the research that you do. You're obviously very passionate about this topic, and I think there's a great need for us to understand a bit more and, normalize what you're talking about, sex and gender. So what kinds of research are you working on right now?
So I'm one of these terrible people who, because I have all of the intersecting identities, I do a lot of DEI work on top of my actual job. So all of the stuff that I just talked about is not what I actually do for research. It's the various committees that I'm on or whatever. But in terms of my research, I'm interested in female health and understanding. So the healthcare system that we have and the biomedical research space that we have developed, it is not built for female patients, it is not built for women, it is not built for queer people. So there's a disparity in terms of where funding goes, there's a disparity in terms of the attention that we give to certain areas, and gynecologic cancer is one of those areas. So I'm working in early detection of gynecologic cancer, so I've got a couple of projects on ovarian cancer and endometrial cancer right now, and I'm working on developing the cell-free methylated DNA immunoprecipitation sequencing method, which my boss Daniel D. Carvalho developed in order to improve time to diagnosis for these tricky to diagnose cancers that have really ambiguous symptoms, say, or they tend to get caught late. So if we can develop a low-cost, non-invasive screening tool that can be easily integrated into the already established care protocols that we have, then maybe we could capture some of those cancers earlier. And CF-MEDIT is one such tool that's I feel a good candidate as a liquid biopsy in order to achieve that.
That's really interesting because I feel like, especially with ovarian cancers, very hard to detect. The symptoms are really vague. And sometimes within the healthcare system, women's symptoms get written off as, it's that time of the month, or are you sure? Have you tried this? Have you tried that? And women's intuition with our bodies is not valued. So I'm sure you found that in your research too.
So I'm very much at the molecular end, but as a person in a female body, having access to healthcare myself, I have definitely felt that. I have noticed that when I drop in what I do for a living, suddenly, sometimes, rarely, it's not a minority, but the bedside manner of the person that I'm seeing suddenly improves.
Right. I know what you're saying.
Yeah. And that shouldn't happen. And it is a minority, but it does happen. What am I actually going to say? Yeah. So with ovarian cancer, the symptoms are really vague. So we're talking about things like bloating in a postmenopausal patient. That is probably nothing. But it also could be anything, and often what that leads to is patients self-medicating for months and months and months before they actually either A, go to their GP, or B, their GP starts to take their symptoms seriously. So there's an education thing at both ends there in terms of the patient and in terms of the primary care providers recognizing this suite of symptoms as something that maybe they need to escalate. The other thing that I wanted to pick you up on there, so it's not just women who get ovarian cancer. So next year is the 25th anniversary of the death of Robert Eades. Robert Eades was a trans man from Georgia who was diagnosed with ovarian cancer in 1996. After his diagnosis, more than 20 oncologists refused to treat him, mostly because vague, nothingy reasons, but some of them did explicitly tell him that their other patients would feel embarrassed. And I recommend checking out the documentary Southern Comfort if you want to learn more about Robert Eades. But yeah, I feel like another thing that would really help in improving sex and gender health equity is changing the language that we use, moving to a gender-neutral language, which is it's really hard to relearn this stuff and to notice when you're doing this stuff, but I think making the effort over a long period of time, it helps reframe the problem in your head and change the conversations that we are having at a societal level. So yeah.
Yeah, I agree. I think that there's a lot of work that we could do from even the healthcare standpoint in terms of forcing functions. For example, our EMR systems are not up to speed in terms of a patient comes in with their health card and let's say it's their dead name. That's what the patient will be called. if we're not flagging it. And that's the problem that I see plaguing many hospitals. So again, really having that informed lens where we're really actually trying to do the work that we set out to do when we're saying we're trying to achieve health equity. So I'm looking forward to seeing what things that you're going to continue to do. We definitely have some work. We have some more learning to do. We've heard some really great things from you, and I look forward to having this conversation a little bit longer. We got to get you on the podcast now, the official podcast. No, so thank you so much, Emma, or Dr. Bell, for coming on our podcast, our mini little series to talk about sex and health. Thank you.